importance of the oral hygiene, so that to make sure that the transmission or the rate of ECC that might be affected, the infant can be reduced. And can I ask whether in Indonesia, do they have this sort of programs, or hygiene, or dental health education to the pregnant mothers? Do we impose? Do you impose that?
Yes, we usually enforce that in our public health center program.
That's great. That's great. Yeah. And the other strategies that we do is oral health education or diet counseling. As we know, diet is most important component. When we receive the patient that come to your dental surgery with the ECC, what needs to be done? Of course, based on their background, socioeconomic, whether we think whether they're going to follow your instruction or not, or they just came to solve their problem, to do extraction, and that's it. Or you can train them, give some dental or health education to make sure that at least they can prevent this from happening to the other sibling or younger one or the coming one. So diet is the most important component that we can talk about when we're talking about oral health education. And we must always talk to the caregivers of the parents to restrict food and drinks containing sugars, giving only at meal times, avoid frequency of sugar, liquid or solid food, whether we accept it or not, we believe it in it or not, we have to mention, it's our responsibility to mention to our patient or the parents of our patients, drink only water and milk and sugar-free snacks between meals. Snack on sugar-free snacks only. Avoid soy milk, juice, and sweetened milk in water. Also, the importance of mention to them to stop bottle feeding at the age of 12 to 18 months. Is it acceptable or not in our culture? There's a question there. Infants should not be put to sleep with a bottle containing fermentable carbohydrates. Are we doing that? Is it a normal practice in our society? Ad libitum breastfeeding should be avoided. Ad libitum breastfeeding actually is a breastfeeding on demand. Even though the whole night the child demand to be breastfeeding, and the mother and the child go sleeping while breastfeeding the whole night. And this should be avoided after the first primary tooth begins to erupt and other dietary carbohydrates are introduced. And parents also should be encouraged to have infant drinks from a cup as they approach their first birthday. And they should be weaned from the bottle at 12 to 14 months of age. So here is the question here, whether is this applicable to our society? But still, it's our responsibility to inform the parents. By right, if we say first birthday, they got to stop, but at least they will remember and then try to stop, even though they can only stop at the second birthday. It doesn't matter. Better second birthday as compared to the third birthday, And the breastfeeding for at least 12 months, stop once first deciduous tooth erupts. So when we're talking about breastfeeding to stop at 12 months, I think this is contradictory to what's medical personal advice to our mothers, should give the breastfed, should breastfeed the child up to 2 years maximum, if possible. So this is something that whenever we look at the guidelines from anywhere, we got to really try to adopt it accordingly to our culture, our practice, and what's available at our place or our area. And again, the other strategy is toothbrushing, which is well known, is most efficient in removing plaque in most young children. And when we address them to brushing, we address them to use a fluoride toothpaste. That should be emphasized since fluoride has been shown to be effective both systematically and topically to prevent the decay. I'm not going to discuss about the way, the technique that we are going to advise the parents, but I think you all know what to advise on toothbrushing, especially the technique of brushing. But again, important for us to acknowledge the parents or the caregivers that the use of correct amount of toothpaste with the age-appropriate fluoride concentration. Because last time we used to be mentioned that way back 10 years ago, you cannot use more than 600 part per million fluoride content in toothpaste for children. Now things has changed. For the child under 3 years old, we got to use the small smear of paste containing not less than 1,000 part per million fluoride. For 3 to 6 years inclusive, use a pea size. Pea size is here. The smear size is referred to this photo. And use a pea size amount of paste containing not less than 1,000 part per million fluoride. And for 7 years old and over, you can use toothpaste containing 1,350 to 1,500 part per million fluoride, similar to adults use. So 7 years and below, we can share the family toothpaste already. And after brushing, advise them to spit only, but not to rinse. But of course, early in the morning, they're supposed to rinse. There are the things to be considered as well. They believe by spit and not rinsing can reduce 10% of caries experience as compared to those who rinse their mouth after brushing. And again, the other way, techniques to reduce ECC is flossing. The flossing in very young child is very debatable. But again, for those motivated parents, I have some parents that come told me that, they floss their child's teeth. 4 years old, 5 years old, they're flossing because some childs have a very, very crowded teeth, even though it's primary teeth. So we can say, yes, you can do flossing, but you have to really be careful. And flossings, not more than 2 to 3 times a week, but should be immediately after brushing. And they got to learn properly, use the proper flossing gadget before flossing the young child's mouth, or teeth. And fluoride, as I mentioned earlier, is very, very effective supplement and can use systematically and topically to reduce early childhood caries, and through water fluoridation and school water fluoridation. And studies have shown, there's a book by Murray saying that, they have a milk fluoridation and also dietary fluorides, salt fluoridation and fluoride in sugar even. In the Western country, it has been done. Some failed, some successfully done. But the most successful, as I mentioned, is water fluoridation that used systemically. And topically, yes, professional application. We do put the fluoride varnish in patient's mouth, and also certain self-application of fluoride, which is not really favorable because it can miss the content or the amount. It can be wrongly used by the parents. So we have to look at that as well. And with fluoride treatment, studies have shown that it's important and it's cost-effective prevention method to strengthen tooth enamel and prevent decay. The high caries risk children receive a full mouth topical fluoride varnish applications with reapplication consistently at 3 months interval. If we use the fluoride varnish, we got to depends on the severe, high risk, moderate, and low risk. The highest risk we can give application of the topical fluoride or fluoride varnish, especially not more than 4 times a year, which means every 3 months, not more than that. And it can only be done by dentists, not to give to the parents to apply at home, because we have other than fluoride varnish that normally can be used by the parents, and we can discuss afterwards. And at home, then following the fluoride application, the caregiver should be reminded not to allow brushing of the child's teeth or eating crunch or sticky or even drinks for the rest of the day, but normally the first half an hour or 1 hour after fluoride varnish application. If we sit the rest of the day, it won't work at all. And this is the amount that we use for fluoride application. I give example of Durafat. Here in Malaysia, Durafat is the most. We have about 6 brand type of fluoride varnish in the market here in Malaysia, but Durafat varnish is the most used fluoride varnish. And then we have to look at the amount that can be used for 2 and 5 years old, about 0.25 mil, and for 6 years and older, about 0.4 mil. And this is the amount, and we give the scale, then we can estimate how many and that we can use per application. And have you heard about silver diamine fluoride? Do you use a lot of silver diamine fluoride here in Indonesia as a topical fluoride or to arrest the caries to apply on the
yes
ECC?
we also use this
silver diamine fluoride. Yeah, great. This is a good stuff. It has been used for a long time ago in Japan and US, but in Malaysia it's not quite favorable, but now it is getting more popular.
I'm sorry, Prof. In Indonesia, also not yet use silver diamine fluoride because I think there's not available in Indonesia right now.
Yeah, it's the silver diamine fluoride in Malaysia per application. It costs around $60. It is quite expensive. Per application, so it's new, but it's quite efficient. Sorry, got to go back. And besides silver diamine fluoride, toothmousse. Are you familiar with the tooth CC ACP? Milk product actually, calcium phosphate peptide, amorphous calcium phosphate. This is formulated first. It's from Australia, I think. The toothmousse produced by GC, and it's quite popular in Malaysia. And the parents, almost the parents that come to see me, if they've been to other dentists before GP, they always told me that they keep using the toothmousse, but things getting worse. The child was referred to me and to do extraction under GA. But in certain extent, it's the effective ways of reducing or to prevent the ECC. So you got to think of silver diamine fluoride and toothmousse, as a tools to prevent ECC. And lastly, I think the fissure sealant. Fissure sealant has shown to reduce pit and fissure caries in primary and permanent teeth. And there is evidence that say fissure sealant is more effective in reducing decay on occlusal surface as compared to fluoride varnish. But the fissure sealant, the procedure is very, very sensitive to the moisture control. It's not that easy to get, especially to the young child, to apply the sealant. And should you able to do to apply the fissure sealant, the child is cooperative, choose the one that material made from GIC, glass enamel cement, because it got fluoride release. It has been shown that although the resin-based sealant are the first choice, but the GIC-based sealant also important as a temporary to be sealed, because it will prevent the decay more because of the fluoride release. And we're done with the preventive strategies. I do hope you can absorb, because lots of text there. And then now we go to the treatment or management of the ECC. And in Malaysia, we have clinical practice guideline in management of severe early childhood caries. And we have formulate that and publish a way in 2010 and 2001, earlier than that. And yes, we have the path of how to handle the early childhood caries, whether severe or just early childhood caries. Follow the whether we categorize them under low risk, moderate risk, or high risk. And normally it's the same. We manage early childhood caries. The management of early childhood caries or ECC is affected by the extent of the caries lesion and the compliance of the child and parents. Now, this is a very, very important statement for everyone. So, as a student or a postgraduate student or as the clinician or general dental practitioner, when the child patient came to you, the first thing in our mind is whether are we able to handle this patient. And sometimes it really gives us up to the nerve. We try to do the restoration, to do the fillings on the child, But don't worry, for me, after gone through almost 30 years dealing with this now, and after 10 or 15 years, you're more complacent, you get more acceptable. Don't worry, sure, I cannot manage on dental chair, why I should struggle, but there's another way, inhalation sedation way, and what's going to do is we put them to sleep under general anesthesia. So sometimes I have to say this to reassure me, to make me able to accept all kind of patients that should come to me. We just know whether they are cooperative or not, apprehensive or not, and now we deal accordingly. There's 4 stages in management of ECC. If we cannot do anything, even though they are not cooperative, don't even let you to see or just remove the decay to clean the tooth. You got to do a strategy of control of the caries process first, followed by stabilization of the caries lesion. And the third one is restorative treatment, and the fourth one, extraction. And the fifth one is if you can't do all this under normal dental chair or dental setting, you can do this under general anesthesia by putting them to sleep. So the control of caries process, the individualized caries risk assessment is important step in the management of ECC. You know how to do caries risk assessment. I assume you know how to do caries assessment, and you will know this patient after take history, asking few questions, sometimes by looking at the patient and the parents, the way the patient talk, already, this patient is high risk or moderate or low risk. And parents should be asked to wean of child from using the bottle while in bed. Patient come to you with a ECC. So how are you going to manage? High risk, moderate risk, or lower risk? Then you got to talk to the parent. Even though some parents don't even want to hear, you're telling whatever you told them, they just want to get rid of the pain, by extracting. That's all. But at least you have to know that you're responsible. You should be ask the parents to wean off the child from using the bottle while in bed. That's always the question that I'm asking. The kids still on bottle or breastfeeding. In case of considerable emotional dependence on the bottle, suggest to use the plain water. So we normally advise, especially the young one, 1.5 years to come with the decay already. I'm so worried. So try to ask them to gradually reduce from put milk in the bottle to the plain water. It's almost impossible. I got 3 pairs. I've done that, successfully done. Then I told this to all my patients. If they say, wow, I don't think I can do that. If they say that, mana bisa. But I told them gradually, like normally we put 6 ounce milk and 6 ounce water in one bottle at night only. The day you give as normal as you are. But during night, you reduce maybe the first week, 4 scoop, 6 ounce of water. And the second week, 3 scoop, 6 ounce of water. The third week, 2 scoop only, 6 ounce of water. And the fourth week, just the plain water. It works. Because it works with my kids. But of course, we're struggling. And then, as a parent, whether is it fair or is it a sin to give a kids at night only the plain water? But it works. It helps a lot. In addition, parents are instructed to brush child's teeth last thing at night with fluoride toothpaste. last thing to be done at night, which is, I don't know whether it can be achievable or not. But I told them at night, just brush, even though it's not the last thing. After brushing, they eat again, it doesn't matter. After brushing, they go asking for bottle or for breastfeed, it doesn't matter, just do it, you know. And effective brushing is important words, not just brushing. And for children aged 3 to 6 years, chest side topical fluoride 1-ish, which is 2.2% fluoride application to teeth, should be carried out 2 to 3 times yearly, as what we mentioned before. So this is the stage of control of the caries process. You do this even though you can give advice only and not able to give the topical fluoride, to apply topical fluoride, the child didn't allow you, it's okay, let them go. And call them back about a month after or 2 months to see what's going on. If they come back to you, otherwise they go to the other clinic, your clinic will just pull the problem tooth and then they just disappear just like that. But you do your part at least. And after the control of the caries process, we go for the stabilization of caries lesions. They come back, and then sometimes if patient is cooperative, at the same session, you can do the stabilization of the caries lesion. If the caries is arrested, they come, you give advice, education to the parents, they follow your instruction. You're lucky, maybe 1 in 10 patient or 2 in 10 patient or 5 out of 10 patient, 5 come back with caries lesion arrested. So it should be monitored to ascertain that it remains as non-progressive stage anti-exfoliation. But at the same time, all the cavitation that you have in the mouth, you should put the restoration with the intermediate restoration such as GIC fillings. And for the non-cavitated proximal enamel lesions, a resin infiltration system, the new resin infiltration, when I say new, it's not quite new. Actually, it's available in the market where you don't have to dig up the cavity. You just put the resin infiltration system with the fluoride to use the caries, to control the caries progression, especially on the deciduous molar teeth on the occlusal surface. And stabilization again, the teeth that require temporization are excavate with spoon excavator. You don't have to remove all the caries because you don't want to initiate any pain, otherwise they will jump and don't be able to come back to you. And then you push glass enamel cement. And it has been shown that although you didn't remove all the decay, the caries, you know, when you put temporary restoration, it is capable to arrest the lesion from progress further. And it has been suggested that the complete dentin caries removal is not essential to control caries progression. And I've done it and then some, but I still want to warn you, even though you put temporary, you got to warn the parents that maybe out of sudden, 1 week after that, they come back, which shows that there's a swelling with abscess next to the particular tooth that involved. You got to warn them, you know, it may happen. It may happen because you cannot say that by doing that, so for sure, you will be arrested and no further progress happen. It is, maybe it can happen, you know. And next is a restorative treatment. So restorative treatment of ECC is based on removal of caries. Successfully control and put the temporary, come back, now only the time for you to put restorative. Because no point you put all the complicated restorative treatment, even though the patient is cooperative, you do all sort of things, but they still go back, practice the same bad habit of diet, not brushing, whatever. And then after all the effort, the cost that paid by the parent, they come back after 1 month, say, wow, your restoration is not good. It become decay again, it's dislodged and the child is in pain. You got to tell the parents, you know how good the restorative, although it has been controlled, and after you've put the restorative treatment, complicated treatment, done nicely, you are very good dental, you have a good skill and your restoration is perfect, but you still got to warn. If they didn't practice a good habit hygiene, it will come back, it can be distort again and recurrent caries can occur. So restorative treatment of ECC is based on removal of caries, and the treatment approach should take into consideration the child risk factors and age. And the choice of restorative material use can be influenced by the site and extent of the decay, child's ability to cooperate, and longevity of the restoration. It's related with the age. Now, the two should be there for next 1 year, 2 years, 3 years, or 4 or 5 years. It must be in your mind while deciding to put the restoration. And the most common used material in restoring the primary teeth is amalgam. Do you still use amalgam in Indonesia?
For now, still not.
Yeah, same in Malaysia. We try not to use amalgam. I never use amalgam for so long, but we still allow to certain extent those maybe the adults might need that, relate with the post crown or whatever. But for children, we try not to use. But most of the Malaysian dentists don't use amalgam anymore. And composite is another choice that we can use for restorative treatment. Glass ionomer cement, resin modified glass ionomer, high viscosity glass ionomer, polyacid modified composite resin, and stainless steel crown. I think the best restorative to prevent or to seal the corona of the crown is a stainless, or is the crown. Is either stainless steel crown or the crown is made from other than stainless steel crown. There is no significant differences in the material for outcomes, as there are not enough clinical trials to support any particular material. There is, but not really say that amalgam is better than composite is better than GIC. Yep. It depends on the location, how big is the restoration, and the habit of the patient, whether it's changed or not. However, studies on longevities of restorations tend to favor stainless steel crown and amalgam over the resin-based material. In young children with high risk of caries, there is a good evidence that stainless steel crowns function better than multi-surface intraoral restoration. In US, yes, any cavitation that involves the interproximal area, the answer is stainless steel crown. It's expensive, but insurance cover the patient over there. Patient don't have to pay. The system is paying, even in UK as well. But not here in Asia, in our country. It's expensive to put the crown. It depends, yeah. But the best is stainless steel crown or the more expensive crown that available in the market. For the anterior tooth, yes, strip crowns with composite restoration is one of the best options. It's cheaper, but really need cooperativeness from the patient. Yes, some of them are very, very cooperative. They can tolerate this strip crown to do composite restoration. And after that, they can be high motivated to take care. And we also use preformed zirconia crowns, which is quite expensive, not quite very expensive. But for zirconia crown, the aesthetic is there, more acceptable for anterior, especially for the and also for posterior for some parents. And durability is more than 15 years, but as we never need the crown to be there in child's primary teeth for more than 10 years, I'm supposed. Yeah. Alternatives to nickel allergic patient, full coverage protection, autoclavable. This is something about zirconia crowns for those who can afford. Those have general practice in high-end area. We do that. This crown, and look what zirconia crown can do. I got this slide from my friends, Muko Jain from India. He's a very, very talented and innovative young dentist, come businessman. Look what he has done to this. He produced the zirconia crown and also silver diamine fluoride and or sort of instrument for PEEPs use. Yeah, so this is a reality that what he's done. He's doing with zirconia crown, and I wish I can have the photo ready, whenever you do this under general anesthesia on a few of my patients. Sometimes, yes, after restoration, done, whatever restoration that you do, I have lots of slides after this to show. And extraction. It's no choice with the tooth that papa involvement. You have to decide whether to do endodontic treatment or extraction. As the ground rules, if more than 3 endodontic treatment requires in the patient's mouth, especially the young one, so it's advisable to extract rather than do the endodontic treatment, especially when the patient is not cooperative. If you put them to sleep, you cannot do endodontic treatment, especially those non-vital tooth in one visit. If the tooth is still vital, to do puppectomy is still appropriate to do under general anesthesia that require one visit, but you really got to warn the parents. You know, should it happens, infection happen again, whatever, then you're not going to put their child to sleep under general anesthesia quite often because it's expensive and it's not indicated so. And extraction of primary teeth in one of the treatment option is managing child with ECC, although the clinician should try to avoid dental extraction during the child's first visit. And the decision to extract should be made after considering both general and local factors. The general factor is patient cooperativeness, medical condition of the patient, and dental infection that may be increased patient mobility. If patient having the heart problems, you don't try to attempt to do pulpotomy or puppectomy because it can cause fatality through the bacteremia and also can affect the valve of the patient and can cause fatal. We don't want to take that risk. If those parents, I have few occasions the parent insists to save, I said, no, I'm not going to do that. You can sue me if it's happened. If they insist, I say, you please find another dentist to do so. I'm really, really strict on this. You know, I don't want to take get into trouble later on. And the local factors is restorability, extent of the caries, which may involve the pulp and roots, and potential for mild occlusion of disturbance in development of the dental, balancing and compensating extraction may be considered. But this is minor for me. The most important to tackle the pain that patient had and to tackle the problem. So all discomfort should go, and with the no discomfort in the mouth, then only patient can concentrate to follow instruction to practice a good hygiene brushing. With all the discomfort, they won't be able to follow your instruction or the brushing and other preventive measure even. So treatment under general anesthesia, if the child is unable to compliant during dental treatment or require extensive treatment, yes, general anesthesia is the choice. And again, whether they can pay or not, it depends. You know, here we have two options: go to private or go to the government hospital. In government hospital, they can pay maybe $600 or 500 Malaysian ringgit. But the waiting list sometimes it goes up to 1 year. You know, how could, you know, in the private setting, under me, it may be around 6 to 7 now, because they have to, used to be 5,000 because of the COVID test, everything. Now it goes to 6 to 6.5 overnight until they got the result before we do the procedures. And in the private setting, private hospital, minimum is 10,000. Oral rehabilitation coupled with regular application of 10% povidone iodine application can be a good alternative to control dental caries in children affected with ECC. For our pandemic COVID prevention also, is the best. Before we treat the patient, we ask them to gargle with povidone iodine application, povidone iodine mouthwash before any procedures done. This is a procedures that can be done under general anesthesia. Complicated, child is sleeping, easy for you to work on patient. Yeah, and if you have to extract, that's a abscess already cannot be said, then you have to. So as a conclusion, the active caries lesion should be temporized with glass ionomer cement to control caries progression. For children with high caries risk or multi-surface lesion, the use of stainless steel crown is recommended, not to attempt to do the good restoration of your scale on the small tiny molars, you know, with a multi-surfaces decay. So might as well easy for you to put stainless steel crown. But again, the cost and then the affordability of the parents is a question there. Non-compliant children with ECC should be managed with comprehensive dental treatment under general anesthesia. So this is an example of cases that can be done if you do it under general anesthesia, or if you can do under normal, if patient is cooperative, parents are willing to bring and then didn't cause trauma to the child, then you can do it under normal denture. Yep, this is the outcome before and after. And again, look at the severity of the decay, and this is the outcome. The same patient, one is not to be safe, and then you can see the permanent is merging there already. And this is the lower arch. See, we replace with a stainless steel crown, and this is a radiograph showing before and after. And this is another example. The fillings, composite fillings, stainless steel crown, and strip crown with composite as well. And this is another example. Are you still able to save this teeth? What do you think? The molars at the back, looking at the clinical situation there, there's an abscess. But here we are, end up with denture. If you can convince a patient really wanted to chew, we can still provide the denture, but the success rate for denture insurance is very, very low. And I doubt this patient also can use how long they can use and can tolerate with the denture. And again, this is an example of the cases that is done. It's complete strip crown and composite, you know. It's not that easy because this is done under a normal dental chair. And with that, I would like to conclude and say that the ECC, the management, prevention, and also the treatment, it still depends on your availability, the situation, the parent and caregiver status, and also your time availability, because it's complete from the dental chair to the general anesthesia or hospital setting. So it depends actually. But as much as possible, it's our responsibility as dental fraternity, especially in pediatric area, pediatric dentistry area, try to educate the parents as much as we could. Of course, they may having problem with the first child, but if it's too late to come to you with a persistent advice to them, maybe they can adopt the good practice for the second, third, and other siblings. And with that, thank you very much for the attention and for the invitation. Thank you.
All right. Thank you, Prof. That was a great presentation. And you have explained detail any strategies to prevent the early childhood caries, such as from education, water fluoridation, diet counseling, toothbrushing, and so on. And also the treatment for early childhood caries. But I'm sure is still any question from the audience. And in the column chat, there are so many questions. There are 6 or 7 questions, Prof, from the audience.
Okay.
Yes. Maybe I'm start to read the first question from Dr. Lucy Damayanti.
Okay.
From Dr. Lucy, she asked about what do you suggest, Prof, to prevent ECC, which in developing countries, the influence of good nutrient and finance their parents, because the healthy teeth of them becoming prevent stunting too.
Yes, they hesitate. Sorry, I tried to figure out where is the question at the chat here.
From Lucy Damayanti.
From Lucy Damayanti. Yep. As we know, the ECC is the most problem in public health. Yep, and the recently research. Yep. So what can I suggest to prevent ECC, which in developing country, the influence of good nutrient and finance their parents, because the healthy teeth of them becoming prevent stunting too. Yep. Yes, it's the same. As we say, not only in developing country, in certain developed countries, this is the problems. You know, the parents, the finance, and because of the healthy teeth becoming prevent and stunting because of this issue, socioeconomic background, and then the level of education is the same. But I think this is a role that should be played by the government itself, you know, to provide the good systematic overall coverage to the dental section. You know, if you have under Ministry of Health, you know, I'm sure in Indonesia you have the same, you know, ways of doing things, you know, and maybe it's more difficult for you to reach to certain area, rural area and remote island, which is very, very far. So, and even though in the town area or urban area also, we have the group of population that also deprived population, and they are not good socioeconomic category that also having this sort of problem. So I think this should be the policy makers should be alerted on this studies that we done and we reported, and then to the ministry, and through political also, you know, it will help to influence them to give allocation more to make sure that, you know, this policy should be done. I'll give example like water fluoridation. And again, got to look at, you have to justify everything that you want. So with water fluoridation in Indonesia, maybe it will get access to how many percentage of population. Yeah, but if not that, the other ways of doing that, maybe it can reach 50% of the population, which is good enough. Yeah, but for another 50, you must find a way of giving the fluorides systemically, and find ways maybe through topical, and you have the mobile dental clinic to go to certain remote area to go to reach the population. We have that with our Aborigine population. We have a mobile dental clinic to go to reach them, even with boat or with the flight even, you know. We have that, especially in Sabah and Sarawak and certain area in Malaysia. So we answering.
Okay, Dr. Lucy. How about Dr. Lucy?
Yeah, thank you, Prof. Very interesting suggest from you. I agree about the we need to advocacy to the government. I mean, from the Ministry of Health, like you mentioned. Thank you very much, Prof.
Yeah, you're welcome, Dr. Lucy.
Welcome, Dr. Lucy. And next, we come to the second question, Prof. This is from Dr. Mila Febriani from Dentistry Faculty, Universitas Muslim Indonesia. She asked about how to early identification of ECC so we can prevent as soon as possible.
Okay.
Yeah.
Early identification of ECC. As I mentioned, I think the parents should be advised to bring their child to see the dentist as early as 1 year old or 6 months after the first tooth erupted in the mouth. You know? So most of the patients that come to see us sometimes at the age of 1.5 years, parents will tell you, keluar saja sudah rosak, keluar saja sudah hilang. Yeah? Even at the age of 2 years, yeah, or 1.5 years. But the dilemma here is not everybody will bring their kids to see you at 1 year old. So whichever that can come to you, that's why it comes like home care, maternity, or the education to the parents, you know, expecting mothers to be aware of this potential problem that will come later on involve with their infant or their child, their young child, or their babies. So we need to highlight this. But when we spot the early childhood caries, when they come to see you at the early age, which is for me is almost impossible, when they only come to bring their kids to see you when they have pain, abscess, swelling here and there. But for those who came earlier, yes, you can plan. The best that I've done is whoever that come, we do. That's why to tackle all this general population, to come to make sure that we can help them from the beginning, these are the programs that I mentioned earlier. Preventive programs should come in, should be implemented by our government, Ministry of Health should implement this. And the problems may be to reach all the population. That's problem. But only ways of doing for, we have to promote beside through Ministry of Health, promote through. Now we have our internet, networking. That's the best way for us to promote this, to encourage parents to come and bring their kids to see for dentist for checkup in government clinic, which is free. I think I'm supposed to just check up, and then from there we can follow up. And we still got to have the strong backup support financially from the government, from the Ministry of Health, in order to do this. Yep. Am I answering?
Yeah, I think Dr. Mila can understand about your answer, Prof. And next question from Dr. Chandra. He want to ask about the prevention of ECC for children who have autism. Is it fine to to perform topical fluoride for autism children?
Yes, autism is a very interesting group of children. I have a lot of autism patients that I treat under GA at different stages, and most of them I have to do 3 or up to 3 GA sessions throughout at the age of 8 and 12, and also teenage, and once up to 16 years old, I still got to look after them, but every time he came not cooperative, I got to do under GA. Yes, autism has many very severe and mild, for those who can tolerate, some of them is very, very beautiful. You feel like put them in your pocket and bring back home afterwards, but some of them you don't really, you say, I never wanted to see him or her, so it depends. Yeah. But again, our responsible for autism, those who can cooperate, very mild autism, if you can manage to seal and put the fissure sealant, fluoride varnish, yes, do so. Please do so, and then it will be helpful. And if you can't, then the other alternative is to put them to sleep. The other way of inhalation sedation, normally it didn't work for autism. I've tried before, it won't work because of the degree of understanding. You don't think that you can put the mask and ask them the question to answer while opening to work on them. It won't work. It's either put them to sleep. And yes, I do look at doing some studies on whatever patient retrospective I've done under autism. Maybe love to formulate when is the best time to bring those children with autism or other medical problems or mental problems, so that we can planning to minimize the needs of to put them under general anesthesia to overcome the tooth problems, at various stage, to minimize the number of sessions and to make sure that they won't suffer a lot throughout their grow up. So yes, as much as possible, if you got chance to give the preventive methods to the autism child, please do so under normal dental child. And normally, I did see a lot of patients with autism whereby the parent is very, very motivated, and some of them quit job, professional work, so just to take care of the kids. And some of them show me all the bruise or, scars, because of the aggressive type of autism that they have, and really, adore the way they take care of. Some of them have one, two, or one mother have 3 autism kids taking care by her. Yes.
Thank you, Prof, for your explanation. So the next question from Dr. Felicia Melati. She wants to ask about zirconia crown. She asks about what is indication and contraindication of zirconia crown in children.
Okay, for zirconia crown, my first indication is patient can afford to pay, patient willing to make sure that they're going to take care and they have a potential to take care of their child's oral hygiene practice, and childs are able to follow the instruction after that. And they are willing to take the risk if it's not working. If anything happen after that, it's dislodged or loose, you got to prepare to explain to the parents to accept that. Zirconia crown is the best for me. And now we have lots of company produce the zirconia crown. Some say that, easily to put in, to stick, and then adopt well with the gingivitis. No doubt zirconia crown adopt well with the biocompatibility with the tissues, But again, the cost you got to think of whether it's worth or not. But the aesthetic is very, very good. Some patients will say, yep, it's worth, parents it's worth, those who can afford. But you don't talk about zirconia crown to those who can afford the cost. And again, even stainless steel crown also, in Malaysia, stainless steel crown costs about 300 Malaysia ringgit. For zirconia crown, maybe around 500 to 600.
Wow.
Similar as, even for the primary tooth, it depends. That's the charging for the patient. But the cost for us in zirconia crown, it can be around $30 or Malaysian ringgit. Yeah, it depends on what brand that you. It's not that expensive actually, but the cost, everything put under GA. Yes, it's indicated, and you got to have a special training for that. Normally, it's done by the company that produce supply this materials, and then there's a lot of conference that offer the workshop on how to put the crown. But the other thing is the market. Yeah, the market. It's the best to be done under GA for me, rather than under normal dental chair. If it was 1 or 2 teeth, yes, it can be done. Yeah, but it's multiple tooth to be done. It's the best to do under general anesthesia. Yep, the indication. You can afford to, you are trained to put the crown. The parents can afford to pay. You got to discuss about the cost, and the contraindication you got to explain the failure rate, and should it happen, you got to explain, because once you put the zirconia crown, they commit a lot of money on that, when you don't want to them to come back to you, say, you mentioned this is the best, long lasting or whatever, but after a few months, it's dislodged. And yep. And again, for anterior, you must make sure that the root treatment's been done, otherwise, it's not really clean. If it's involved the pulp, you must make sure that you protect, because as we know, the corona seal is the most important. After you do some fillings, root canal treatment, or even the big fillings, corona seal. And the best corona seal is the crown. It doesn't matter stainless steel crown, zirconia crown, or other type of crown. Thank you.
Yeah. Thank you, Prof, for your explanation. And how about Dr. Felicia?
Yeah, from Dr. Felicia Melati, yeah.
Yeah, right, Prof.
What is the best treatment for white spot? White spot, okay, meaning white spot is the initial decay. Yeah, the best is fluoride. It can be remineralized. Yeah, the best is topical fluoride application. Topical, it could be, I think the best is fluoride 1-ish. yeah, or other stannous fluoride you apply, or the, and then everything that we do in dental, especially in pediatric, must come with a oral hygiene advice, education, re-emphasize every time they came, and beside topical application of a fluoride that we give, and we hope that it will re-mineralize and become normal again. To a certain extent, the white spot can be re-mineralized, and the enamel can back to normal. Yeah. Right.
Okay, thank you so much for the explanation.
Okay, thank you, Prof. And maybe this is the last question from Dr. Gigi Cherry. And she would like to ask about, a lot of parents use tooth wipes or tooth spray to their baby when their baby first tooth come. What is your opinion about that? Because a lot of parents usually use tooth wipes and tooth spray because they are difficult to brush their baby teeth.
Okay. May I ask, you mean tooth wipe is wipe their baby's tooth with a maybe wet cloth, or spray? What do you mean by spray? Spray the water on the tooth surface, or spray using any material? Can I get some clarification on that?
Maybe Dr. Cherry, can you?
So, okay, I assume that this question is related with the wipes. To wipe meaning wiping the tooth, cleaning the tooth using the wet cloth or towel, yeah, beside instead of using the toothbrush, which will be easier. And also, but I'm not quite sure. But to spraying, I assume if spray with the plain water and then wipes the plaque or the dirt on the tooth surface. I think this is a normal practice. We advise the parents, the younger child, at the beginning, even before the tooth erupted, we ask them to clean the gums area using the white cloth, wipes the gum to clean up, sometimes to avoid the accumulation of the murks, particles, that can cause candidiasis also as part of cleaning process. We advise them to do so. But when the tooth is just erupted, sometimes it's difficult to brush, because it's not all the kids can accept the toothbrushing. It's traumatized sometimes, and it's might be painful if you use the mild or hard bristle, toothbrush. So it is advisable to use the white cloth to clean at least the tooth surface. It can be used rather than nothing. Why not? And it's a part of my advice to my patient as well. To a certain extent, because because for younger child, I will advise them to, beside talking about brushing, effective brushing, gargling. Gargling is very, very important to me. I yet to think of, maybe we can do, anybody got some data or want to do collaborate research with me, regarding gargling. Because gargling for me plays important roles, because I always advise my patient, twice a day brushing. If you can brushing 3 or 4 times, it's better. But if you brush twice, morning and afternoon, at school, during recess, after you eat, before go back to school, go to the classes, must gargle very hard, not gargle. Some of the patients, when I ask them, of the child, ask them to gargle, they don't even know how to gargle properly. I ask them to gargle properly. How? After eating, not after brushing, because sometimes we don't want them to gargle too much after brushing. We want to speak only, to a certain extent. But for gargling, and also during weekend, you go to supermarkets, the mall, maybe not now, but when the pandemic is over, most of the kids during weekend go and eat in the mall. So after eating, please gargle hard, but speak slowly. I did mention that to them.
This is Dr. Chandra asked about the wipe the wipes is like wet tissue that contains xylitol.
Yep, that would be fine. That would be fine. It can be used whether plain water. If you add xylitol, so okay, as long as chai is acceptable. No allergies, no xylitol, and make sure that it's not swallow the xylitol. But if you wet tissue that you squeeze, not soaking, I think it's okay. It's acceptable.
Right.
Yeah.
Okay. I think all the question has been answered, Prof. Thank you very much for your explanation and also dear audience for the active participation. Hopefully the presentation will be beneficial for you all. And once again, thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh. I will give it back to the MC, Dr. Yosi.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Professor. Thank you very much, Dr. Sakriani. That was a very wonderful presentation and also a very active discussion. I believe that some of participants still have questions, but we hopefully Professor Sabri Musa will still can join us in our next event that will be held by Faculty of Dentistry and University. So we can still meet again in the next time, Professor. Hopefully.
Inshallah. Yeah.
Inshallah. Our virtual symposium today also can be accessed from in our live streaming in YouTube channel, of course, in Dentistry Faculty of University, and also from our Facebook, Fakultas Kedokteran Gigi, Universitas Hasanuddin. And before I end this session, there will be a delivered of a certificate virtually that will be delivered by our Dean, Dr. Gigi Muhammad Ruslin, MCAS PhD, SPBM Consultant, to our speaker, please. Okay, Dr. Ruslin, there will be a delivered of certificate virtually to our speaker.
Yeah, you already hear me? Hello?
Yep. Yeah. Yes.
Loud and clear, sir.
Thank you very much, Dr. Yosi, for the certificate. Thank you very much, Professor Sabri Musa, for your kindly support us. You give again lectures. This is the separate time you give some discussion and improving our knowledge in our faculty. And this is your certificate.
Thank you very much, Prof.
Thank you very much, Professor Sabri.
Thank you very much. Hopefully we'll see you soon.
Yeah, hopefully the coronavirus gone and then we can meet each other again.
Yeah, maybe in KL.
Yeah.
Yep.
I hope so.
Yeah. Thank you. It's my pleasure.
Thank you very much
for inviting. And
yeah.
Thank you very much. Thank you very much, Professor and Dr. Ruslin. Now, at the end of our session today, there will be a closing speech that will be delivered by our beloved Dean of Dentistry Faculty of University. Please, Dr. Gigi Muhammad Ruslin, MCAS PhD, SPBM Consultant, the floor is yours.
Yeah. Thank you very much, Dr. Yosi. Assalamualaikum warahmatullahi wabarakatuh. Good day, ladies and gentlemen, and our honorable guest speakers, Professor Sabri Musa, as the Dean, Faculty of Dentistry, University of Malaya. It's an honor for me as the Dean of Faculty of Dentistry, Hasanuddin University, as the host for the 6th Virtual International Symposium Series, the Prevention and Treatment of Early Childhood, to present a closing statement. On behalf of a Virtual International Symposium Series Committee, I would like to express my gratitude to all of you who have spent your time and participating in this virtual event, which has enabled us to conduct this international symposium virtually. My gratitude to the Vice Rector, Professor Dr. Masrum Nasri Masih, PhD, Specialist Microbiology Clinic, as representative of Rector of Hasanuddin University for the great support for this event. It's always an honor for us to receive such support. Highly appreciation to our speakers, Professor Dr. Sabri Musa, our valuable colleague from University of Malaya, very close, we are very close, for sharing his knowledge and wisdom, and has a long history of friendship with us, and I am sincerely thankful. To all participants, can see some of participants that has joined us today come from different province, different city, and also different island. We are very happy for your participants, and hopefully we still able to meet you again in our next event. I have understand that this virtual symposium has eliminated distance boundaries between us. Therefore, we can still gather for such scientific meeting even in pandemic situation. It's my hope that this virtual symposium as the expression of our commitment in strengthen the knowledge and skill of dentists and also specialists in pediatric dentistry, particularly in prevention and treatment early childhood caries. I also thanks my college, the organization committee for their support job in making this meeting happen. Again, thank you very much, and assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Wilson, for the closing statement. Now this is the end of our virtual symposium for today. Thank you very much again, ladies and gentlemen, for all of your participants, all of your active discussions, and Professor Sabri Musa, thanks again. This is a very valuable sharing of your knowledge, of your intelligence and wisdom to us here. And hopefully we can see you again in our next event. And it will be an honor for us to have you with us, of course. Maybe next time not in a virtual way, maybe in a live way, in a direct way.
In
Hopefully.
Kuala Lumpur ya, we going to Kuala Lumpur.
Oh ya boleh dok, nanti ke Kuala Lumpur dok. Kalau pandemi sudah
Amin.
lalu.
Semoga Prof. Sabri kita bisa ketemu secepatnya.
Ya, insyaallah saat ini.
Insyaallah, thank you so much.
Amin.
Baik, terima kasih banyak untuk semua partisipan. Kembali lagi kami informasikan bahwa this is our virtual international symposium series held monthly. Setiap bulan kami mengadakan, ini adalah yang ke-6. Dan tentu bulan depan kami berencana mengadakan kembali untuk virtual international symposium series yang ke-7, tentu dengan materi yang juga tidak kalah menarik. Dan all of our presentation you can rewatch it in our YouTube channel Dentistry Faculty Hasanuddin University, and also you can get the link through our social media in Facebook and also Instagram. Once again, thank you very much. Wassalamualaikum warahmatullahi wabarakatuh. Selamat siang, sampai jumpa.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
wabarakatuh.
Saya keluar ya. Terima kasih.
Ya, makasih banyak.
Terima kasih Prof. Sabri. Terima kasih Dr. Yosi.
Ya, Dr. Edmi, Dr. Yosi, Dr.
Saka, Dr. Asrina, Dr. Nisrina. Selamat bersolat Jumat, Dok.
Ya.
Saya izin leave.
Ya.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih Pak Dekan. Pamit ya.
Pamit.
Terima kasih,
Dr.
Prof.
Edmi,
Terima kasih banyak semua.
Kamu kok 12:20, Mang. Iya.